And good afternoon, everybody. Welcome to this session on New Age Visualization, 3D Surgical Microscope, and Intraoperative Assistance Technologies. Along with me in this session are Dr. Krishna Prasad Kudlu. He is the moderator for this session, and Dr. S. Natarajan, Dr. Naren Shetty, and Dr. Sandeep Reddy. I think some of the speakers are probably held up in other presentations also. So we'll be starting this session now. The first speaker is will be Dr. Sandeep Reddy. I would now request him to give his presentation on markerless versus conventional toric implantation. Dr. Sandeep Reddy, please.
Hi. Hello. Good afternoon, Cyrus. Good afternoon, Sandeep.
Good afternoon, sir.
Good afternoon, Dr. Natarajan.
Yes.
Welcome.
Thank you. Thank you. Sandeep, your father is there?
He's not there, sir. He's little not feeling well.
Okay, Cyrus. His father has got the Lifetime Achievement Award yesterday.
Thank you so much, sir.
Okay, carry on.
So, good afternoon, everybody. I hope my screen is visible. So, today I'm talking about the markerless toric marker using the Zeiss cataract suite, the Callisto. So, in my practice, when I started my phacosurgery, I was always very apprehensive in taking up these correcting the astigmatism. Astigmatism is about 50% of the outpatients have some kind of an astigmatism before undergoing some the cataract surgery, which I think it is becoming a mandatory to most of us that we have to correct. But there is always an apprehension that if you do a manual toric surgery, whether we can give the patient the ideal results or not. So we have two markerless torics present in our market, the Callisto system and the Varion system. The Varion is from the Alcon. So today I'll be talking about my experiences with the Callisto system. As you all well aware that one of the best IOL optical biometry is the IOL Master 700. This IOL Master 700, the Callisto and the microscope, the Lumira I family of microscopes together can be integrated into a single system, which is called the Zeiss cataract suite, to which once the patient gets the data from the IOL Master 700, it can be easily transferred to your microscope on your surgical table. So what does the IOL Master 700 or the 500 does is it takes the picture of the eyeball and it marks the limbal blood vessels, and it marks the astigmatism can be marked, and then it will be transferred to the Callisto system in the OR through your LAN cables, or it can also be transferred if the LAN cables are not available in the OR. They can be transferred even using a small hard drive. And this, whatever the image that is transferred onto the Callisto system is then transferred onto your microscope using the AD system, and it can give you a precise image of the cylindrical marking that can be done. So by this, it increases the efficiency of your workflow, and all the manual pre-op markings can be skipped, and you don't have to unwash yourself to mark each and every patient. And the manual transfer of the data can be skipped. It makes your life much more easier, and the things become much more accurate. So what does the IOL Mark 700 does is there is a reference image which automatically gets acquired along with the keratometry. You do not need any extra instrumentation to have the cylindrical marking like what the Varion has. Everything can be done using the IOL Master. The image used, the same images are used and transferred onto the intraoperatively into the microscope. And as you all know, the gold standard biometry is IOL 700. That is what is being used by most of us. And the uniqueness of these keratometric values are they are telecentric. They're telecentric in the means it actually concentrates on the visual axis rather than the center of the pupil. And the Rexis guide that also comes is also telecentric. That means it concentrates over the visual axis. And if you actually observe during the surgery, you will understand the Rexis is not the center of the pupil. Most of us try to do a Rexis, which is the center of the pupil, but it should be a telecentric, which helps in multifocal IOLs. And the swept source biometry, the swept source, the OCT images that also come gives you, there are other advantages with the other speakers would speak about the IOL Master. And you can see here, this is how an IOL Master takes the reference images. You can see the nasal and the temporal images are taken. And these images, what the IOL Master takes are superimposed with the images that are taken from the telescope. And you can see the blood vessels are each and every blood vessel is coincided. And then these images will give you a reference image, a reference line, and the toric alignment as required from the axis. So, so this is how an image that comes in the and the other advantage what this Callisto also has, it has got a HD recording system along with it. You do not require an extra video camera to be attached to record all your videos. It has got a 1 GB memory inside inbuilt into the Callisto, and it is attached here, and it gives you a 3-chip HD camera is completely attached, so that all your surgical videos can be recorded as per the data that is stored from the IOL Master 700. I will I'll share you one of the videos. So this is a patient, very high myope, undergoing a cataract surgery with an astigmatism of 3 diopters. And you can see the incisions can be, the incisions are all marked. It is a 179 degrees incision, and that can be aligned. After that, you can see the Rexis can be adjusted the way you want. For example, this is a 4.5 mm marker, and this is a 5.5 mm. So it gives you a very good assistance in doing your Rexis. And if you actually observe carefully, this Rexis is not in the center of the pupil, but it is as per the visual axis. So that is the meaning of telecentric. It actually concentrates. Now you can see the Rexis is not exactly in the center of the pupil. It is little towards the nasal side. And when you are actually seeing these images, the quality of the surgery is not at all compromised, because you can have a good visualization of the surgery as well as these marks. And you can have multicolored options also as per our requirement that can be changed. Here I have kept it as a blue, which is by default it comes like that. You can see I have made an exactly 5 to 5.5 millimeter Rexis, which actually gives us a very good guidance. Because when you're doing in a high myope or in a large eye, sometimes it is difficult for us to tell what is 5 mm and what is 3 mm or what is 6 mm. Unless until you don't have a proper guide, it is very difficult for us to tell what kind of Rexis are we making. Sometimes we think it is a small Rexis, but actually turns out to be very large Rexis sometimes. I'll skip the surgical part and the phaco part. This is a very high myope. That is the reason why I'm inserting a toric IOL. So I mean a CTR ring, so that the space in the bag actually comes down a little, and the toric lens will have a better stability. So this is how the marker actually shows. You have 3 lines that can come that shows the alignment of the IOL. You have to generally you have to keep the toric marks on the IOL, so as parallel as to these lines possible. So I'm using a plate haptic Zeiss toric lens, which actually come in 0.5 diopters variations, which gives us a very good option. And you can see clearly that these marks are exactly oriented parallel to the, see the mark here, as per the, and once we are finished with the lens implantation and orientation, we have to do a slow hydration procedure so that the lens do not rotate. So actually, by using the Zeiss Callisto system, the IOL Master, and the Lumira microscope, the complete cataract suite, it has made my life much more easier. And my conversion rate today into doing a toric IOL has increased to almost 13 to 15% from the previous 5%, less than 5% of my cataract surgeries were undergoing toric IOLs. But now my confidence levels are much higher, that where I'm doing about 15 to 20% of my cataract cases, we do toric IOLs. And the only disadvantage what I feel the general ophthalmologist will face is from the Varion system is you need to have a Lumira family of microscopes for sure, and to have the Callisto system. And IOL Master is a compulsion to have for the cataract suite. While the Varion system can be attached to any of the microscopes, and the Varion system does not have any kind of a recording system at all. So overall, I would feel if you have a Lumira microscope and an IOL Master, the Callisto will add up to your practice and will give you the best results to your patients. Thank you.
Thank you, Dr. Reddy, for a very nice lucid explanation and exposition of the advantages of this technology. And I think definitely it makes life a lot easier for the anterior segment surgeons. Next, I'll be speaking on the complex retinal procedures. So there are no financial disclosures relevant to this presentation. These are my acknowledgements. My colleagues who have helped me in the preparation of this presentation, and some of the videos are also theirs. So talking a bit about digitalization in ophthalmology, we remember the time when the digital angiography came in. Purists scoffed at digital photography, but then we know that as resolution improved and hardware and software advanced, the digital completely took over. So when we are talking of the heads-up microscope, the RTO800, is this a new era or is it just a new toy? Some of the major advantages which we find with the heads-up system in the Lumira microscope is the surgeon comfort. You can sit upright. It's much easier on the neck and the back, especially for the older surgeons like me. There's high magnification, good depth of focus despite high magnification, excellent resolution at high magnification, especially at the posterior pole, where one finds one can do ILM even without staining. All observers can have the surgeon's view. So it's a great thing for teaching and for supervising fellows as well. The low light exposure for patients, there's less chance of light toxicity, ability to change color values of light. The blue light is good for high myopes, albinotic fundus, green for detecting subtle vascular proliferations, and in yellow you get less reflection under air when you do a fluid air exchange. One of the USPs of the RTO system is the ability to switch from screen to microscope view without needing to change from the microscope head to camera. This is the inbuilt camera. Some surgeons just prefer the direct view. Even now, in certain situations, we do switch to the binoculars. And even the question of digital software or hardware issues, in the rare occurrence that there is a breakdown, you have the reassurance of the backup of the binoculars. And in this system, the lag is reduced to an imperceptible level. Some of the disadvantages are OR logistics. The cataract surgeons sit temporal while doing combined surgeries. We sit at the head of the patient, so that sometimes can create some logistics issues. Assistant sometimes has to turn the neck to see the screen. You need more space. The placing of the vitrectomy machine, anesthesia machine, and the microscope have to be carefully planned. And we need to keep the screen close, about 1.5 to 2 meters at the most from the surgeon. Sometimes during the surgery, especially we get intraocular structures or reflective instruments can cause more glare. Working in the periphery sometimes poses challenges. And the dynamic range of a digital system still cannot match the human eye. So you have to vary the illumination much more while you are operating. The intensity of the endoillumination, the sensitivity of the camera or the software system, and need a trained person at hand to do this while you concentrate on the surgery. So this is the setup we have for the heads-up surgery with the RTO system. The future definitely is digital. We know this from digital imaging, phacoemulsification, advances in refractive surgery, that technology ultimately refines as systems will be refined and costs come down. Change is the only constant, and we can't stop the march of technology. Coming on now to the complex retinal procedures. So in the retinal posterior segment space, proliferative diabetic retinopathy, complex retinal detachments, trauma, and massive subretinal bleeds are some of the rather complex situations which we can encounter in our practice. And bimanual surgery is often helpful in this. As this little video shows, bimanually you can do something much more easily when you're trying to tie the shoelaces with one hand. So wide-angle systems give us a good view to the periphery, and smaller gauge instruments enable us to work closer to the retina. Both these, along with the self-retaining endoillumination devices, give us ideal conditions for bimanual microincision vitreous surgery. Coming on to PVR, major components of PVR are fixed retinal folds, equatorial circumferential contraction, anterior loop traction, and subretinal bands. And we'll see that in some of the subsequent videos. This is a PVR case, and you see that there's a tight contract fold at the posterior pole, and the retina is relatively stiff and immobile. And this thick membrane is being now gradually eased off the posterior pole and brought anterior. And now this membrane is brought up to the equator, up to the vitreous base, which is as far as it will go. Here we see again another fixed fold here, which is being relieved. And once this is relieved, the retina in that area also becomes much more mobile. Having tackled the posterior traction, now you see that there is an anterior loop here, and we are trying to relieve that so that the retina settles well, and we especially don't get any recurrences in the late stage, especially after silicone oil removal. Here we see it's a very anterior pathology. We can work under microscope light with one or two instruments, and with the forceps and scissors, or even two forceps and a stretching maneuver, that traction there in the anterior space is relieved, and then the scissors removes that tissue. Having done that, the anterior retina also becomes much more mobile. And once the entire retina is made mobile and the anterior loop is also relieved, we go ahead with the fluid air exchange. So here's the retinotomy there and the fluid air exchange. The retina settles and then the silicone oil will be injected. This is another case where the retina was held taut by extensive subretinal bands. And again, we see how bimanually it can be elegantly and efficiently removed. We see how this hand-on-hand maneuver with the two forceps, we are removing this extensive subretinal band. This is one of the largest I think I have ever removed in a PVR situation. And this is the entire band is sort of folded up. And even then the nasal side was still stiff and there was still more in the subretinal space. Now we see this thick subretinal band being removed from the subretinal space there nasally. Once that is done, the retina becomes much more mobile and can settle it and put silicone oil. Moving on now to diabetic retinopathy. Proliferative diabetic retinopathy again can be very challenging. Here we see there is fibrovascular tissue and subhyaloid hemorrhage, but there's no elevation of the posterior hyaloid at all. So even here trying in the periphery, we could not get a plane to start dissection. So we made this.
We are not able to see the video. Video is not playing.
This one or even the previous ones?
The previous was playing. Now the PDR is not playing. Previous was excellent surgery.
I am able to see it. Is no one able to see that?
Can Dr. Reddy or anybody from SAIS can see it?
Yes, the video is not visible.
You have a slide saying PDR creating plane when posterior highlight totally adherent.
Yeah.
And we are not able to see the video playing. Link is there. Link Dahya VTS VOB.
I think that link needs to be clicked and then a video player will open.
Okay. Maybe I'll do the other videos first and then.
Okay.
Yes, surely, not a problem.
You can do that. But the previous surgery was very good. Now this is plain.
So this was another case of PDR where there was the fibrovascular tissue. Now the last part is being removed. This was a young diabetic, an army officer. And after that, we still found the retina in the temporal side looking stiff, and we found there was some subretinal hemorrhage. Now, subretinal hemorrhage we do encounter in diabetics, but usually it's mild. But since the retina was stiff, we now put in a PFCL bubble to protect the macula and then decided to remove that subretinal hemorrhage. And to our surprise, there was this huge clot. And then finally, we removed this clot bimanually. it was tending to spring back. So again, with the same hand-on-hand maneuver as we had used for the subretinal band, we removed this rather large subretinal clot. And once that was removed, the retina looked a lot better and more mobile. And then with the usual fluid air exchange, and then we used gas in this case. This was a case of subretinal hemorrhage that colleague Dr. Charu Gupta presented. This is again massive subretinal hemorrhage, and this sort of a hemorrhage you cannot remove through just making a small retinotomy. So we had to make a large peripheral retinotomy and reflect the retina over. Here you see the retinotomy being extended. This was a trauma case. There was a vitreous hemorrhage and subretinal hemorrhage. Here you can see a lot of the hemorrhage in the subretinal space. Sometimes it is subretinal, sometimes even it can be sub-RPE. And then you have to really decide how aggressively you need to go after that and what part of the hemorrhage can be left alone to avoid removing huge areas of retinal pigment epithelium. Thank you for your attention. Should we try and go to that video? Oh.
You can go to that video. But excellent surgery, Cyrus.
Thank you, Nati.
Nice to.
Doctor, are you able to play that video that was left in between?
Yeah,
He's trying that. Now we have one speaker less, so Nirup, we can have a Cyrus video.
Yes, we can absolutely.
How it's playing?
No, it's still in the, what do you call that? Some all slides are seen. No, we are seeing all the slides.
Yes.
Because I went into the folder and clicked on the.
Okay. So I got the problem, Dr. Cyrus. What you can do is you can stop the screen sharing.
Okay.
Now, once you stop the screen sharing,
Is it giving me that option? Yeah.
Okay. So now the screen sharing has been stopped, right? Now what you can do is go to share screen again.
Share screen. Okay.
Okay, there you can see that you can see 3-4 tabs, right? So you can see one screen.
The one which has the video. Yeah.
Yes. Now it will be visible. Yes. Please click on that. Please click on the folder where the video is. Yeah. It's loading.
Has it come on?
No, it's opening, I think. You have to click again, I think.
I think, doctor, there's a problem with the playback. You can try playing it again.
You click again, yeah.
Yeah, just double, yes, play. All right, or one thing you can do is, I think there's some sort of a playback error. You can go back to the PowerPoint presentation where the link was present, and you can try clicking it and opening it from there.
I don't want to waste too much time with everyone.
It's fine. We can have 2-3 minutes extra as we have one speaker less, and there would be ample amount of time towards the end for the discussion.
Yeah, yes.
Share screen. Go back to the presentation.
Yeah, go back to the presentation.
Yes, click on share screen. On the left hand side, you will be seeing screen. Just click on that. So your screen would be shared. Yeah. Now go back to the slide.
Yeah, this is the one.
But you have to share screen again.
The screen has been shared, no?
No.
No, your screen hasn't been shared, doctor.
Now is it shared?
Yes, now it's shared. Yeah,
Now the screen is
absolutely.
there.
Yes, just click on the link that's there, and that might redirect you to the VLC media player from where the video will be played. Yes, just click on that.
That's what I had done the first time.
Okay, so what happened is just click on OK. Yeah.
Now it's playing.
Now it's
Now it's playing. Yeah.
Okay. Chalo, good. Thank you.
My
So
pleasure.
we find that the plane in the periphery, we cannot find this. And so we make the incision over the area of the subhyaloid hemorrhage over the macula and between the macula and the disc. And then we find from there we can extend this hyaloid separation over the disc and then see where this separation happens easily. Here it's in the lower nasal quadrant. We can find that we can extend this peripherally, the separation, and then kind of almost like a rexis, turn it around circumferentially, and we find this gradually this hyaloid is separating from the retina. So we separate as much as possible, which can happen with just a controlled and gentle traction so that it separates, but without creating a retinal break. And if there's any area which is more adherent, then we would leave that alone for dissection later on. So now all this fibrovascular tissue is removed and the case is closed with a gas exchange. Thank you for your attention. And I would now request Dr. Natarajan, again, he will also be speaking on complex retinal procedures,
Yes.
3D visualization.
Okay. Thank you, Cyrus, for a wonderful presentation. Now, how much time you use the 3D?
Now it's been...
No. What I meant is, in a given day, all surgeries you do under 3D or...
No, it can't be all surgeries because actually one moves from one theater. This is in one theater.
I know.
So maybe about 1/3 of the surgeries.
Oh, okay. Good. So I'll share my screen now. So you can see my screen?
Yeah.
Okay. Thank you, Cyrus. I converted myself. I know it's there in one theater only. So I decided, even if it takes some time, and I decided to operate only in one theater. So that I tell them others can do all other theater. So I use the word 3D fantasy surgery, vitrectomy for proliferative diabetic retinopathy, no financial disclosure. And all of us know diabetic blindness, the challenge, it's an epidemic happening, and every diabetic gets affected in some way or other. It's an incurable problem, and ocular symptoms too late, and prevention is better than cure. So you see, you just saw a patient where Dr. Cyrus showed, which is a fantastic surgery, how he created the opening and then seeing the cleavage. And you in India, you see so much of severe traction retinal detachment. And other indication will be non-clearing, which is hemorrhage, and combined traction and rhegmatogenous retinal detachment. And this is a taut posterior hyaloid following a proliferative diabetic retinopathy, producing fibrous tissue and contracting the macula. And then you have this, once upon a time, rubeus iridis associated with vitreous hemorrhage was a contraindication. Nowadays, I give intracameral anti-VEGF, and a day later, I do the vitrectomy and do an extensive pan-retinal photocoagulation. Earlier, I was also adding the cryo, but now I don't do, and because of the wide angle, you can do up to the ora. And in case you can't see periphery, you can TIPRESS, and even in a phakic eye or a pseudophakic eye, you'll be able to go up to the periphery and do as much as of laser possible, and also add anti-VEGF same day. Even though you're given a day before, usually we expect the things to get, even though there can be a systemic absorption, and systemic absorption takes over a period of a few days. So I think the next day you can add it as a severe eye, otherwise they will result in severe neovascular glaucoma. And diabetic blindness, the diabetic macular edema, traction retinal detachment, and neovascular glaucoma are the conditions where we can do vitreous surgery. We know all this, but in spite of that, vitreous surgery is required. And vitreous surgery is to restore, maintain vision. The surgical objectives include thorough removal of the blood, end of photocoagulation, and reattachment of the macula. So here we have a case one, a diminution of vision in both eyes since 2 days. He's a diabetic since 11 years on insulin, on poor glycemic control, came with blindness in both eyes, only vision counting finger close to face. On examination, he had vitreous hemorrhage with diabetic traction retinal detachment in both eyes. Right eye followed by left eye vitrectomy was done a week apart. And here you can see the vision improved to 618 after 6 weeks. You can see the phakic eye, and usually I don't like to do a combined at that stage because in a diabetic eye, still the lens acts as preventing the posterior vascular growth factors to migrate to the anterior segment. So if you have the lens in position and then do the vitrectomy, and then in case the cataract becomes more, and you can plan for a cataract with IOL. In some eyes, you use silicone oil where it can be combined with silicone oil removal. You can see the vitreous hemorrhage is removed, and then now the tangential traction is being relieved, and then you see the fibrovascular proliferation. I'm doing endodiathermy to make sure that bleeding does not happen. And I always keep the pressure on 20 and operate, because diabetic eyes, there's a possibility of optic disc becoming pale. And you see, in spite of the diathermy, there is some ooze, but I think you can again trim it and then use the diathermy to diathermize the bleeding fibrovascular proliferation. And the whole idea is to remove the anterior-posterior traction and the tangential traction. Still some retinal hemorrhage happens, and which can be cleared using the retinal brush. And in the previous to the anti-VEGF era, and we used to have severe recurrent bleeding as one of the cause for vitreous lavage or OPD fluid air exchange, which is a multiple procedure needs to be done. Now, giving anti-VEGF pre-op, then vitrectomy with a gas and laser, I think the chance of recurrent hemorrhage is usually almost minimized to 5%, and then more. Even the 5%, you may not need a vitreous surgery, because the advanced vitreous surgery clearing all the traction and make sure good endolaser photocoagulation done is actually grown. And this sort of eyes where blindly you cannot give anti-VEGF pre-op, so we have done the vitrectomy, and at the conclusion we give the anti-VEGF, so that and again at the end of 1 month if required, performing OCT and angiography. If need, you enhance with further laser photocoagulation as well as anti-VEGF injection. So you can see fluid air exchange done, and that's the advantage of using the biome where you can, or any other wide angle where you can work under the air. And so, because the view is so good, and particularly using the 3D, here you can't demonstrate that, but using the 3D, you'll be able to see well. And only another advantage of using the 3D is whatever you see, all in the OT, including your assistant, can see. And this is the case to proliferative diabetic retinopathy with a preoperative visual acuity of 2/60 with a fibrovascular proliferation, as you see here, and post, and this is the intraoperative. You'll be seeing this is a 25 gauge vitrectomy, and I make sure I do this tangential entry so that the wound closure is, wound construction is very good. Here you see the fibrovascular proliferation, and again relieving all the anteroposterior traction, tangential traction. And I use the vitreous cutter itself and remove the pre-retinal hemorrhage with a, and here I'm actually using the proportional mode in between, where I actually push the fluid between the membrane and the retina. So that the idea is, this is what is a proportional mode, where you can push the fluid between the retina and the fibrous tissue. It takes a little more longer time, but only thing you don't have to exchange instruments. You can also do a bimanual surgery. Again, I think I don't go with the idea of doing only this technique. I do depending on the eye. And then here you see, after making a cleavage and making a fibrous tissue a little more mobile, I make much space and then go to the convex side of the fibrous tissue and then do a cut and trim that. This is what I meant as convex side, so that you keep on trimming, and thereby you can remove the fibrovascular proliferation which is adherent to the retina. Only thing is you can see that again I'm using the proportional mode to push the fluid between the membrane and the retina, and you can see the membrane is extending from the disc to the periphery, and then here again I'm doing the same. You can see the fluid being flushed between the membrane, and you saw the blood gushing out. So it's actually creating a cleavage, and I think it's like using a gush of water as a blade of knife. And you can use the pre-retinal hemorrhage to clear the pre-retinal hemorrhage which happen, and then do a fluid air exchange. And because repeated bleeding happens, and you can see that the view is hazy, but you can do a thorough endolaser photocoagulation and replace the eye with gas. There is some nuclear sclerosis. We can wait and see. Usually the patient vision improves, and there is a patient has improved. Disc is failed, all membrane is removed. The visual acuity is 6/9. This is the third eye. We had a combined retinal detachment with the cataract in a proliferative diabetic retinopathy. I have Dr. Kavita Rao who does the cataract. I don't do cataract, and she does the phaco with the intraocular lens implant, and then I take over and then do the cataract. I do the, she does the cataract, removes the cataract with the phaco, and then introduces the foldable lens. And then after that, I take over and do a 3-port pars plana vitrectomy. And all this is, you can do a sutureless. Even if you do a belt buckle, you can make scleral flaps. We use the vascular sleeves, so there's no sutures at all. You can do a cataract, vitrectomy, and belt buckle totally sutureless. And I think modern surgery aims at airtight watertight surgery, and you can also you can see there are multiple entries made, and I think the advantage is that you do everything in a micro way, so that the wound healing is better, handling of the eye is much better, so the inflammation is much less, and many times the next day the eye does not look like it's operated, and that's where you learn tissue handling and also tissue care, including conjunctiva, and then here she's introducing the foldable intraocular lens. And the advantage of using the 3D RTO is the surgeon like Kavita Rao sometimes doesn't want to use the 3D, but she uses the binoculars and the microscope, because you can have the binoculars up when you're not using the 3D, but the recording will be in 3D. And now I take over and make a 23 gauge entry and do a 3-port pars plana vitrectomy after the lens is in place. And then I do the anterior vitrectomy, posterior vitrectomy, and then clear the vitreous hemorrhage, and then if the traction. So all the vitreoretinal procedures are done, and so you can see now the vitrectomy is in progress with organized vitreous hemorrhage. And you can see there is a fibroscular proliferation on the nasal to the optic disc. So the airtight, watertight incisions done. The cataract helps in the, and also making the port. You can make the port. And if here I'm doing the diathermy of the fibrous tissue, you can see a rhegmatogenous combined retinal detachment. So I'm also diathermizing the edge of the break, but right now I'm diathermizing the fibrous proliferation, and I'm delineating the fibrous tissue from the retinal detachment. So here you see there is some amount of subretinal blood is there, which I'm also removing. And you can use the vitreous cutter, use the suction and remove the blood. And this is, I think, a fresh blood which has happened in spite of diathermy when you're doing. And now the entire subretinal blood is removed. The adhesion between the fibroscular proliferation and the break is also severed. And now I'm again dissecting the fibrous tissue and the near the break, and you are seeing pre-retinal hemorrhage which has happened, which is also I'm clearing using the vitreous cutter. And I am diathermizing the edge of the fibrous tissue and the break so that the attachment can be severed, so that there's no traction persisting after the completion of the vitrectomy. Here I'm using the vitreous cutter and removing the pre-retinal bleed. So that the idea is not to get out instrument, put a vitreous brush, the backflush needle, but you can use this. You can see now I'm clearing, and this is again diathermizing the fibrous tissue. And the reason I've done the diathermy around the break is to identify the break, because once you do a fluid air exchange, many times the break is totally closed, and then break becomes smaller and you will not be able to identify. So this you can see, and I'll be doing an endo laser between the around the break as well as between the break and the retinal break, so that the in between retina is totally laser. And here again I'm magnifying and identifying the fibrous tissue and severing the connection between the fibrous tissue and the retinal break. So finally the fibrous tissue is almost trimmed and there's no traction on the break. There is some ooze happening. I'll do a diathermy. So now you can see that I'm severing the attachment, and it's all away from the optic disc, because you have to be careful when you are actually diathermizing near the optic nerve, because it can produce optic disc pallor. No point in doing an extensive vitrectomy and having an optic disc pallor. So I'm using PFCL up to the fibrous break, which is in the nasal side. I'm now using the PFCL as a third hand, and then using a vitreous forceps to grasp the membrane and sever the attachment. So I'm judging the how adherent it is by lifting the fibrous tissue. So now I'm able to remove the fibrous tissue en masse, and you can see I'm having the PFCL, and then using the retinal brush, I'm going into the retinal break and doing an endodrainage and fluid air exchange, and so that the entire retina is flat, and you can see the retina between the optic disc and the break is also flat, indicating that there is no traction, and the PFCL makes sure the retina is flat. And then you do make sure the entire retina is subretinal space and the periretinal area is dry, so that the entire eye is filled with the air. And under air, we can do the endolaser photocoagulation. And being with so much of traction and then present, and I prefer to use a silicone oil. And I thought if there is and then we can remove the silicone oil later once the eye is stable. And I'm doing using the curved probe, the endolaser under the air. And here I'm doing the laser in the in-between retina, between the break and the optic disc. And you should do a thorough pan-retinal photocoagulation, except the optic disc and the macula, so that all the anoxic retina is ablated, so that the need for the oxygen content will be less, so that the optic disc and macula can function well and the patient can see well post-vitrectomy. Because I'm completing the endolaser, and then finally removing the PFCL which is there. This is again at the completion of pan-retinal photocoagulation. I think this eye I didn't use oil. We left the eye with the hair and a pseudophakic at the end. And this is a final video, I think. It's a twin light vitrectomy for proliferative retinopathy, which allows excellent illumination. And this is a very old video. I'm just showing managing the complex proliferative diabetic retinopathy. You saw Dr. Cyrus Shroff technique. You saw the previous cases. And now this will be a bimanual. I'm using a twin light designed by Class A Cut from Frankfurt. And the idea is that it gives a beautiful illumination. Nowadays, you can use multiple Paul-Tornam as chandelier illumination, single light probe illumination, which can be illuminate. It's like illuminating the whole hall with one halogen light. So here you see using the curved vitreous scissors. I'm using the forceps to pull the membrane, identify the cleavage, and then dissect the membrane slowly so that we can remove the membrane en masse. And every time, even though it looks fibrous tissue, but in fact there's some vascular element which is there because of the long-standing fibrovascular proliferation, which can give rise to oozing. And in these sort of eyes, if you use anti-VEGF pre-op, there is a risk of traction increasing and producing a problem. So you can avoid anti-VEGF in these sort of eyes, and you can use the surgical maneuver to remove the membrane. It needs meticulous dissection and patient surgery, and a persistent and a precise surgery is required. So I'm even segmenting and then delaminating and then finally removing the tissue bit by bit, but maybe en masse. And then you can remove the tissue for studying also using the microscopy for electrohistopathology. So you can see the membrane can be removed this way, and then the entire membrane is being, and there is some ooze happening. If it is a mild ooze like this, you can wait. But if the ooze is keep happening more, and if you don't remove it in between, there's a possibility sometimes the blood gets stuck with the retina, and then removing that becomes a problem. So better to remove the blood in the controlled fashion. And here the ooze has stopped, so I'm waiting and proceeding for the blood to get clotted, and then remove it at the end. And here you can turn the scissors and you can remove the membrane. You can see almost all the 90% of the membranes are removed. The last part is being removed, and then so I think in the 90s, the 19 to 20% was the risk of iatrogenic retinal breaks, and now I think it has reduced to the minimal. And that's because of advanced illumination, advanced viewing system, as well as advanced vitreous surgery and micro instruments, which makes the complications lesser. We can't say complication is zero, but complication is lesser, and the least complication is what a surgeon should aim. And here is another bad traction retinal detachment, again using the same technique, using catching the membrane and then removing. So I think that depending, and here you see the membranes are being removed, and most of the membrane is removed, and then you can use a PFCL and an endolaser PFCL air exchange. And many times in these sort of eyes, when the retina has been lifted for long, I prefer using the PFCL to flatten the retina, do the endolaser, and then do the air oil exchange. So the favorable preoperative factors: short duration of macular detachment, limited extent of detachment, presence of preoperative pan-retinal photocoagulation, absence of vitreous hemorrhage. And a favorable preoperative visual acuity 5/200 or better, absence of rubeosis, absence of retinal detachment involving macula. Unfavorable are macular detachment and combined retinal detachment, and that's the patients you saw. Now, even in that, I think the 3D vitreous surgery for PDR is very good. 3D vitreous surgery is a revolutionary technology to change the way the surgeon performs VR surgery, benefits both the surgeon and the patient, and can be widely accepted platform. And the posture which Dr. Cyrus mentioned, this is a 3D Ingenuity by Alcon, and I don't have any financial interest, and this is RTO. It has the digital optics, add vision, cloud connectivity, hybrid mode, auto adjust, and it's the first digital microscope, the new era of visualization in ophthalmic surgery delivered by the first digital hyperoscope and without compromise. And it has the digital evidence, which is outstanding. AdVision has the digital assistance. I don't have the OCT, but we can have the OCT and the cloud connectivity. And this is an auto adjust, which you can see. And this is how the system works. And you can see the brilliant OC there. And then this is a hybrid model. And then advantage of the experience of the posterior segment surgeon, best combined with for the surgeon's neck remains relaxed, but I feel exercise is important. And posture at the microscope.
Sorry to interrupt, doctor, but could you please wrap up in next 1 minute?
Yeah, I'm doing that. And then it has a good adaptability. It's an advanced teaching tool, and that's what I'm enjoying using this. Now I'm trying to talk with the cyber side how we can transmit the 3D vitreous surgery. You see the entire operating staff can see that, and whatever you're seeing, you can. So I think we have to screen so that we can. This is my the 3 generations of ophthalmology. So thank you very much for a patient listening. Thanks to my fellow secretary.
Thank you, Dr. Natarajan, Dr. Kudlu here. I was part of other session moderating in the whole session. That's why I joined late. Sorry for apologize for that. Sir, my one question to you, being such a fantastic surgeon, I think I've been seeing you many years. One question I want to ask you. See, you've been operating under the microscope. When you got this 3D system,
yes,
how many cases you really took to incorporate into this particular system? How many cases you really get adjusted for doing this?
See, I'm that way a bad example, because even when the Alcon I didn't buy, when they came to demonstrate, the engineer came from Tokyo and was trying to explain. He was originally from True Vision company. And then he was telling me, you have to do this and you have to do this step and the 5 procedure and all. I said, no, because I don't know whether there's a book called Concise Mastery by Richard Green. He talks about Leonardo da Vinci, how he was not trained as an artist, and Michelangelo. All of them have got something like that. So I think we had an excellent mentor, Dr. Badrinath, and then we have learned what to pick up. So I think I always found this because I operate in all the operation theaters all over the world. And then smallest place like Nagpur in 90s. I remember Prashant Bhawankule as a PG operating. I've done vitrectomy standing in Calcutta in 88 when Dr. Nagpal. I used to wonder how can we do, but we have done that. I have done with indirect. So I think the question here is, I can drive an ordinary Fiat to a Mercedes 7 Series or the BMW 7 Series. So I think it's a question of if you're a good driver, you can do anything. Same thing here. I'm a bad example because I didn't take even one case. I just told nothing doing. Whatever you want to give a lecture, you keep giving lecture, I will do. So my hands, my legs speak with the machine. So I could adjust in first case itself. And that's why I asked Cyrus, the operation, the microscope is there in 1 OT, but I don't want to do any surgery. I do buccal removal, I'll do anterior chamber, anything what required, anything and buccal, anything under the 3D microscope, because I have imagined myself sitting on the optic disc and working. And this is how I'm trying to create in a science center in Mumbai. I want to create a walk-in eye model and stand on the optic nerve and look at the lens and the pupil, which is the same thing I'm doing when I'm operating, because you can, between 2 layers, like this is there, like this, you can see it in this level in the 3D. And I think it's a real beautiful teaching. Only problem is the cost is not equal to enjoying this. But anyhow, as a surgeon, I'm enjoying. So I'm glad. And thanks to Cyrus and Darius. Darius is my mentor, because I took some time to decide. I was questioning, is it worthwhile spending this much money? So when Cyrus bought it, I was convinced. Sri Ganesh bought it. I thought, okay, he's a, he's like a Bollywood surgeon. So I thought he's doing it for style. But then I realized I asked him, then I asked Cyrus, and third was Dr. Aditya Kelkar. And that particular time we had problem in some alignment, but I think that.
Sorry for the interruption, doctor, but can we please have the next presentation? And at the very end, we have 15 minutes where we can have a good whole long of discussion.
Thank you. Yeah, we'll try to conclude. Don't worry. So, good afternoon, Cyrus sir. Also, the next talk is by Dr. Naren Shetty. He is the vice chairman of one of the leading hospitals in India, Narayan Nethralaya. He'll be talking about the markerless workflow cataract suit. Over to you, Naren.
What, Naren? I want to spell it as WISE.
Right. So, right. So, thank you so for the introduction. On this onset, I'd like to thank Zeiss and the AIOS for giving me this opportunity. So today I'm going to talk about Zeiss EQ markerless workflow cataract suit. Now, all of us keep thriving to be efficient, to save time, and indirectly save cost. But what is efficiency? Efficiency is doing something better what is already being done. So let's look at what is already being done. We have been using these markers for quite some time, but errors happen because there's no reference point. Errors happen because of the head tilt, cycle torsion. Sometimes when you excessively wash the cornea, the marks go away. As you know, every 1 degree of misalignment of the toric lens, we lose about 3% of its corrective effectiveness. And when we use the three-step technique of manual marking, which is the first marking is done at the 0180 at the slit lamp, then intraoperatively it is done at the 0180, and also the marking is done at the intended axis where the lens has to be aligned. Now, when we do this three-step procedure with the bubble marker, has been found a mean error of axis about 2.48 and a total error of toric alignment about 4.9. Now, this is where the Callisto comes into picture. Now, this is nothing but a markerless system, and which gives you an intraoperative, overlay in the microscope itself by taking the data from the limbal vessels, which is acquired during the acquisition of IOL Master. Definitely, I think in terms of a full package machine, IOL Master is the machine to go for. You have everything from formulas to where you can wirelessly transfer your data and so on and so forth. But moving forward, this has a lot of features from creating the intended incisions from, let's say, if you want to plan your incisions from your main ports to side ports to correcting of your astigmatism, from ARC, OCCI, whatever it is, you can enter the data. Once you've entered, you are rest assured this gets wirelessly transferred to your OT, and you get an overlay compensating the cycle torsion. Now, you can also do your capsular axis, which will be perfectly centered, and you can decide what size you want to. And which is extremely crucial, especially when you're doing a toric or a trifocal lens. Now, obviously, you can align your toric lens too. All my toric patients, I always use a CTR. As you can see here, I implant it under irrigation. Once I've implanted the trailing part of the CTR, I hold it with a microforceps and place it into the bag. With this, I'm rest assured that by mistake also the CTR doesn't slip into the sulcus. Now, why CTR in all my patients? As you can see in this is an immediate post-op OCT, where you can see a huge gap between the posterior capsule and the lens. This is one of the reasons why there is a higher chance of rotation during the early post-operative period. But when we implant a CTR, what happens is basically we expand the bag, bring the anterior posterior capsule together, closer together, that way increasing the contact between the capsule and the lens. Here you can see post-implantation of the CTR, there's a beautiful contact between the posterior capsule and the lens, and this prevents from the rotation during the early phase. It also has an eye tracking, so if at all the patient moves his eyes, you do not need to worry. This is how it looks like, where the markings on the lens, you need to perfectly align with the three-line overlay, which you can see through the microscope. Now, what's the difference between manual marking and markerless system? Actually, quantity of vision, absolutely no difference, but quality of vision, there is a significant difference, especially if you're using a toric trifocal lens. It makes a huge difference, not just when you test. In fact, the patient itself appreciates a huge difference in terms of quality. There are a lot of studies showing the same. Now, when you look at the evolution of microscopes, it started in the early 1920s. Then in the late 1920s, the binocular microscope came to picture. Then in the 2014, the modern day microscope came to picture. Are we actually progressing or regressing? This is where the 3D visualization system of Zeiss RTO comes into picture, where with the coming of the 3D visualization system, we have taken care of three people. First, the doctors, the second, the patients, and then the trainers. So let's look at the consultants first. Yeah, as you all know, I think it's been an occupational hazard where a lot of doctors, ophthalmic surgeons have a lot of issues with their neck and back. This is because of a constant operating or bending, abnormally while you're seeing in the slit lamp. So especially like you see in the image, when you're doing your training, you really struggle. And with the coming of the 3D system, you can just simply relax, sit back, and then, just operate without, bending or sitting in a very awkward position. Now, when we're looking at taking care of patients, how do we take care of patients in this? Since we started operating on the 3D system, we started using very low illumination. In fact, we did a study where we have shown there's a significant difference in illumination between a 3D system and the standard operating microscope. And as you all know, the lower the illumination, the patient is more comfortable. Eventually, the patient is more cooperative. And the surgeon also feels nice when he's operating with the patient because the patient is looking at the light. The next thing is trainees. Trainees have really, it's a boon to them. From the time it's come, the learning curve has completely shortened. And in terms of viewing, you don't need to limit yourself to one or two. There is n number of trainees can come. You just have to have a cheap 3D glasses and you wear it and you're good to go. And absolutely no discrimination between any trainees, be it a trainee who just joined or let's say he's the senior-most trainee. No matter who it is, from day one, he will be seeing through the 3D microscope, which is very important because the first thing of picking up your skills is, the depth perception. And that will definitely with the 3D system, it is, you're learning about depth perception from day one. Now we have all the best machines and the best hands. Is that enough? Absolutely not. All of this has to be connected and this should be a seamless one. This is where the Zeiss EQ workplace comes into picture. Basically, what it does is it brings all the machines in your hospital all onto one platform, which is the EQ workplace. And it does through a wireless platform called as a forum and connects everything. Now let's look at what happens in the OPD. First, if a cataract patient comes, then we do the biometric measurements. This is wirelessly transferred into your through forum into your EQ workplace. Now, not just the biometric data, your topography, 3D, OC, whatever it is, everything will be at your EQ workplace. And this can be accessed from any computer, be it your office, or suddenly you can access it in your home, in your OT, wherever it is, you can access this data. Now, whenever you do login, first thing, only once you need to do this is you need to personalize certain things. Let's say if you are you always use one particular formula or one particular IOL company or the quantity of order quantity and email. So once you enter these data, you don't need to keep repeating it again and again. Now the next thing is IOL calculation. Sorry. Okay, perfect. So coming to IOL calculation, one of the key features is everything gets auto-populated, and then you get options of the lens, and you can select the lens which is appropriate for you, and then just press the order button, and you're good to go. You can do your surgical planning in your office itself, and this will be wirelessly transferred to the OT in terms of your toric IOL placement, or OCCIs and so on and so forth. But let's say one of those days you're not able to do it in your office, it got late, you're going home. If you have a long drive, you can do it on your phone itself and transfer all this data from your phone to the OR directly, or just review your other surgeons, what have they planned also, you can do it. That is a beautiful feature. Now, in the OR, let's say you have decided the lens, you have taken the package of the IOL, and you just need to scan the IOL, and this data is uploaded onto the EQ workplace. Now, in the post-surgery visit, you can personalize the IOL consent. I feel this is a beautiful feature where you can, for each doctor or each IOL which is being used, you can really personalize the constant and really tighten your results. Now, all of this, does it really improve efficiency, or is it just a gimmick? So what we did is we did a study where we looked at EQ, toric IOL EQ workplace before the EQ workplace and after. So when we look at the before EQ workplace, this is how the normal flow goes. And let's say time ranges from 8 minutes, 30 seconds to 62 minutes, 30 seconds. Now, after the EQ workplace came into picture, so this is how this is the time we took. It took about 55 seconds to 1 minute. So almost, let's say the best time, let's take it before EQ workplace is about 8 minutes. So we save about 7 minutes, around 7 minutes per patient. Now, this is how the intraoperative flow normally goes, with and before and after the EQ workplace. Most of it is common, but there are two places where we save time, and we save about 7.5 minutes in the OR. That means for each patient. Normally, we operate about 100 and 150 surgeries per day. So that means we have saved about 750 minutes, which is a very significant time. And the same scenario is in the OR also. In the OPD also. Now, let's leave all of this and let's get into the patient's shoe. All of us want a patient flow don't want a patient flow to be long and inefficient. We want the patient flow to be short and sweet. Now, let's look at a toric workflow without EQ markerless workplace. Now, on the day of surgery, these toric patients usually local anesthesia is applied not just once, in fact twice, once at the slit lamp and then once just before you start the surgery. Now, as you know, the more number of times you apply the local anesthesia, it is pretty toxic to the epithelium, and this leads to punctate epithelial erosion. So this creates a lot of discomfort for the patient on the day of surgery, a lot of watering, redness, photophobia, and also decreased vision on the day of surgery. But when we look at a toric workflow with the EQ markerless workplace, there is absolutely no added step, for a toric patient as compared to a monofocal patient. The patient just simply comes in and goes out, and his overall experience is fantastic. He's so much more comfortable. His visual recovery is much faster. In fact, he's recovered his vision on the day of surgery itself. So I would like to conclude by saying we need to be efficient, not just at work. We need to be efficient in the rest of the time in our life. The smallest work that we do, just like, let's say brushing your teeth or wearing your dress, keep thinking of how efficiently you can do. That way, no matter what work you do, you'll be rest assured, efficiency happens at a subconscious level. Thank you for your time.
Thank you, Dr. Narayan, for an excellent presentation.
Thank you, sir.
Dr. Kudlu, would like to comment or ask any question?
So, this is what I pick a point that, see, the large volume cases, when they're doing 100, 150 cases per day, the time is also very, very important. That is what Naren was telling. Almost he saved around 750 minutes, which is very big number. And the accuracy also, because of all this wireless system, you do with ILMaster 700, then transfer the data into the OT. Then even I think you can see you at your mobile also whether the lens is available or not. So overall, you can heading towards, in spite of a busy practice, still you can give a quality treatment to the patient.
Absolutely, absolutely.
Yeah, I think it's a significant advance, and it definitely reduces the chances of errors also.
Very true, sir. In fact, you can even, let's say you want to review what other surgeons are planning, because that is a little sensitive thing, but that's what you can do. You can actually see what have they planned. Sometimes, you're worried whether the toric has been planned properly. Are they doing the incision? Or generally you're curious on how they are doing the plan. You have a chance to, review. Being the head, you have, authority to, get into any logins and have a look at the full list of, the patients and see how the work is done.
Dr. Natarajan,
Yes.
One question. The excellent videos and surgery, really nice presentation. One thing is always kind of foxed me when we conclude these complex diabetic cases. You would possibly remember Dr. Steve Charles' dictum about no tear, no air. There is this thing.
Yeah.
But in some of these extensive traction detachments, even if we have completed the surgery without a break, I am not very comfortable leaving so much fluid, and some of it is thick fluid. So I tend to sometimes make a retinotomy and drain off this fluids, because I feel that this will hasten, even if I have to put in gas, it will hasten the recovery subsequently. What is your opinion on this?
Usually, in case if a break happens, then I use it for doing endodrainage. But otherwise, what I do is sometimes I use the PFCL to almost up to the ora serrata, and then exchange with the PFCL oil, and then leave it. And then so the idea is I don't make retinotomy if I can't find the subretinal fluid or a sclerin happening. So I leave. Then I do the PFCL oil exchange so that at least I know the retina is flat and complete the with endo laser.
Right.
So we have got any one more talk in this session, no, sir?
That I believe Shivakumar told me that one more talk is not there. That's why we are using time.
Sandeep Reddy's talk is over.
Yeah. Sandeep talk is over.
Yeah. Then I think we are concluding this session.
Kudlu, do you have the 3D with you?
No, sir. I am not so rich like Dr. Natarajan, sir. I practice in a very small place. You visited my place.
Yeah.
I'm from Udupi.
Since I have blessed you, Krishna is there, you can become richer.
No, sir. But I am having Callisto markerless system. I am having, but that RTY 800 microscope I am not having.
No, sure, sir. No, I agree. See, that's what I told before you came. The idea, because I'm really enjoying doing it, not only for teaching, but I think even for the patient, it benefits. The problem is, even as a patient calculation, when you do a cost analysis, you can't explain to the patient, okay, this is the whatever 5% better you got benefit operating this, which the patient is not going to appreciate. And we also don't know how to put it, the money part is there. So I think the balance is a problem, like economy and charging. So that's where I think
having markerless system in place like Udupi itself is big, sir. IL Master 700 with the Lumera with the markerless system.
Yes.
But after putting this, my quality of surgery has been improved much, especially when I'm operating toric multifocal or toric trifocal or plain toric lens. The standard of surgery and even results are fantastic, sir.
Exactly. No, I think I remember when Alcon came with the FACO 90s. I think in Sangli, Dr. Patwardhan, Dilip Patwardhan bought it, and he could do because of the numbers, and he charged less. The same thing was in Bombay, was 4 times the professional charge. So I think if you have a number, probably you can make more patients to and less cost. And the problem is again, I mean, everybody cannot come there. I agree with you. It's a win-win you have to create.
Thank you,
Dr.
sir.
Kudla, I don't think you need to feel sort of deprived or apologetic about it. I think one can do wonderful surgery even if one doesn't have the 3D system. So
I think we have to be, as Cyrus conveying, I think finally your mastery of your technique is important. So you have to be the master of the technology, and you should not be a slave, because I think Naren also will agree, he's using a lot of technology. They're also using AI. We are also using AI. And AI cannot dictate terms with you, even though it is like Alexa and then Google Assistant telling you do this, do that. And I think it's dangerous, no? You can't listen to them. It is like worse than a girlfriend. The technology is like that. They tell so nicely, and I'm sitting there. The Alexa tells me, oh, do you want to know this, and do you want to do this? And I don't want to do anything now.
If the wife hears this statement, then the wife will be worse than the worst girlfriend.
Jan Wurst used to make this statement in the AIOS meetings, used to come long ago.
Yeah.
Used to say that if where technology is mastered, you reach disaster faster.
Yes, I think
ultimately the surgeon must be the master and not the technology.
Exactly. No, that's what I say. See, I think we have to master the technology. And I always told, even the AI, even though the machine is learning, in the Dropout movie, what do you call that? It's a scientific fiction where they examine that the robot wants to have sex. So I think the question is, I think somebody has created the robot, no? And you're also trying to put that. So I think it's our human brain who's doing it, or the fellows who are hacking the systems. They're all intelligent people. So I think the intelligent people use the technology to spoil somebody. And same way, I think intelligent people should use the technology to master it and give the best to the patient.
I totally agree, sir. I mean, definitely, I keep telling my fellows and trainees also that, I mean, even when I started, I wasn't very picky on the machine which I got, whichever the OT was free. In fact, I should not select my camp patients also, because all the fellows used to slowly take away the easy ones. The complicated, eventually I end up getting. But those are the things actually which teach you, because if you keep, getting spoiled with the golden or the silver spoon, then you won't know when things go wrong. But having said that, I would say is we need to have that fine balance between technology and so that you go hand in hand and don't fall back also. So it's very important to,
Yeah, no,
go with the technology.
I don't know whether you saw a 6 months back, the robotic surgery, the major surgery, I think the patient died. And I think that's because of something went wrong and he couldn't control the thing and then it cut the wrong thing or something. So I think that always, I always wonder, because this 3D surgery, I see you can be replaced by robotic surgery, where you look at the screen and operate. But again, I mean, the AI coming in, so many things coming in, there's a possibility it can happen. So I think you can't leave everything. It's like autopilot. And I think even in the autopilot, suddenly the weather changes, which is not predicted. And if the pilot is not alert, it's a problem. And I remember in the flight sitting, and I think the main pilot, the co-pilot was sleeping, and the pilot went to the toilet, and it is an autopilot, and suddenly something happened, and he had to run. I mean, you will running, you can fall down also, no? That's why you put the seat belt and all that. So I think the systems are there to keep you alert. And then when the main pilot gets up, the co-pilot has to be active. He cannot be sleeping and say it's in autopilot. Where I've sat in the pilot cockpit for long, and I know what they do. I mean, many times it's like it's in the straight highway in the US, and half the time they put it on that whatever, what do you call that ride, and then you'll be having coffee and listening this and that. But suddenly in India, you'll have one bullock coming or one calf coming, and you cannot have that auto system to be there, no? So I think that finally the question here is, I think we have 2:22. I think 3 more minutes. I think the technology is important. That's where I think the size is no financial interest. But I think definitely you have to maybe master the technology, and I think we should be up to date. And that's where I think Cyrus and myself and you and even Kudlu I think no place is small, Krishna Prasad, because Dr. Suhas Haldipurkar started with me in Dadar. And the Bombay people, the so-called Bombay people, that is Bombay Hospital, Cuff Parade people said, Dadar is not in Bombay. They thought it is, but Dadar means laborer area. Now I'm in Vadala, nobody knew. Now I have created, now I understand, tell what is Vadala. So I think there's nothing like small and big now. Yeah? If you go to any village in Germany, Heidelberg is a village. And what equipment they produce and what surgery they have, what university they have, no? If you go to...
One question to Naren, I just wanted to ask. See, you have told about in your experience that within one case you got adjusted to the RTO 800. I think Naren also, I think, started doing with the RTO 800. How is how much case you really took to get adjusted to the new system?
I mean, to tell you the truth, sir, I mean, this is my actual experience. When I saw the system, I saw how it worked. I saw videos and, people doing. I thought it's going to be difficult to get used to. I mean, that is the truth. But actually, when I did my case, my first case was an intumescent cataract. And I did my case, believe me, at some instances of the surgery, I used to forget that actually I'm seeing a screen and doing. It is so,
Same field. We are operating under microscope.
Absolutely not, sir. I mean, you won't get that feel at all. It's only if you keep thinking, oh, I'm operating on 3D system, maybe that will create that. Actually, if you just forget and just operate, that's it. You won't, absolutely, you'll not have any kind of trouble. Definitely.
Dr. Kudle, I would also agree with that. I don't think somehow with this system, and especially since the lag is very, very, very low, is very little, there's the learning curve of the surgical part as such is really not there almost. As both Dr. Natarajan and Naren mentioned, I think from almost the first case, you kind of just get into the flow of things and you hardly feel any problem. The more important things is the logistics of it, the OT setup, this thing, that has to be carefully thought out. I think those issues are something which the way the monitor is placed, who is going to be checking on the system, somebody who knows the system is monitoring it while you are doing it. So I think those issues are more important. The surgeon
also, sir, cleaning the spectacles, the 3D spectacles also has to be maintained properly.
Correct.
So one thing good about the 3D glasses is very, very cheap, sir. I mean, even if you go and buy it online, you get extremely cheap because there are two types of 3D glasses. We have one active and one passive. This is the passive one. Passive ones are very cheap to buy, but the active ones are pretty expensive. Some of the TVs come with that. So that's one big, I'm very happy that, Zeiss has gone ahead with the passive 3D.
Good. I think
I think we've, yeah, if there are no more questions, should we kind of wind up now?
yes, I think so. Yes. Because,
Sir,
Thank everyone.
thank
Thank
you,
all the
sir.
speakers for the wonderful presentation. And thanks, Dr. Kudlu, for being able to join us and for moderating this session. And thanks, Zeiss, for providing the platform for this very nice session. Thank you. And
Thank
Thank you, sir.
thank you all and have a nice day.
Thank you. Thank you so much to one and all. Thank you so much for being here and gracing your presence and enlightening the entire environment of Hall D with your wonderful knowledge. Thank you so much, gentlemen.
Thank you to the wonderful AV team also. Yeah.
Thank you. Our pleasure. Thank you. We'll catch you soon. Till then, bye-bye.